Hello, and thank you for joining the Donut of Destiny. This is a special industry-sponsored episode. References to a specific product, process, or service by speakers during this podcast do not constitute or imply an endorsement by the Society of Cardiovascular Computed Tomography. The views and opinions expressed do not necessarily reflect those of the Society of Cardiovascular Computed Tomography. Thank you for joining us.
GE Healthcare is a proud sponsor of the Donut of Destiny. At GE Healthcare, we see possibilities through innovation. We're dedicated to providing integrated solutions to make hospitals more efficient, clinicians more effective, therapies more precise, and patients healthier. Together, we're creating a world where healthcare has no limits. Make sure to see more today at gehealthcare.com.
Hello, everyone, and welcome back to the Donut of Destiny, the podcast on all things cardiac CT for anyone interested in cardiovascular imaging. My name is Praveen Ranganath, and I'm a radiologist from Dallas, Texas. On today's special industry-sponsored episode, we add another installment to our Building a Cardiac CT program series. Joining me is Dr. David Furman, a diagnostic radiologist and division director of cardiothoracic imaging at St. Luke's. David, welcome onto the podcast.
Hi, thanks for having me.
David, thanks so much for joining us. Before we dive into the information about your cardiothoracic imaging program, let's learn a little bit more about you. Could you talk to us about your journey in radiology and how you ended up in the cardiac CT world?
Sure. I started out at Mount Sinai in New York City, where I did my residency and fellowship. And back then, in the early 2000s, we were using a 16-slice CT scanner to do some of the early CT angiography of the brain. We're looking to show that you could do angiography to detect small aneurysms. So we were kind of early in doing that. And when I started at St. Luke's in 2004, we had early on acquired a VCT, a 64-slice VCT scanner, which at the time was state of the art. And there were coronary CT angiography articles happening. And we thought, well, we've got this great scanner. Let's give it a try. And so, I had done a cross-sectional imaging fellowship, but I had not done a chest fellowship. But I kind of grew into cardiothoracic imaging from my interest in coronary CT angiography. So I've been doing it a long time, and yeah, that's the basics of the story there.
Yeah, David, since 2004, you've sort of seen the evolution of the origins of cardiac CT into its modern era now. And I want to talk about how your specific health system is structured as we build into this current modern cardiac CT practice. So give us an idea as to the general size and structure of the St. Luke's health system that you're working in, as well as the role that you serve within it.
Well, we've been very fortunate. So when I started in 2004, we were 3 hospitals, but we're currently 13 hospitals and 5 outpatient centers, and we're operating 30 CT scanners. So yeah, we've grown quite a bit. Obviously, as we all know, coronary CT angiography has grown quite a bit. So my role in it is as the division chief of cardiothoracic imaging. I do a lot of cardiac imaging specifically. So we've been trying to grow our cardiac program, I guess, which is what we're talking about here today.
Yeah, awesome. There's, of course, a tremendous number of components of building any program: hardware, software, staff, radiologists, cardiologists. Why don't we start at the top? Hardware. How did y'all go from the hardware systems that you had in we'll call them the earlier days in the 2004 and maybe late 2000s era into modern day? What sort of main decisions were made to shift from previous technology into newer technologies?
We had been kind of operating almost entirely on that one VCT scanner because, as you know, demand for coronary CTA was not enormous in the decade in 2010 to 2020. So we were trying to, kind of increase our volumes, but we had a lot of struggle. There was not a great reimbursement. environment for coronary CTA at that time. And we were a smaller network who was growing at that time, so it wasn't our focus. Our fleet of CT scanners was starting to age by 2020, and I think we had a great relationship with our administration who recognized that we have this aging fleet of scanners, many of which were nearing the end of life status, and they began discussing the purchase of multiple scanners at one time. So they were discussing that with GE, and what came about in, I guess it was 2022 that we finally finalized the agreement, but there was an agreement to do something called platforming where we would purchase 23 GE scanners at the same time to be installed over a long 5 to 7 year period. That agreement was finalized in 2022, and our first scanner was installed in 2023. And so that corresponded with the real growth and demand for coronary CTA. There's so many factors that we could discuss later that have increased the demand for this kind of imaging, but a lot of it has to do with the quality of the scans that we can get. So that was the main part of our kind of more rapid evolution that happened in the last 5 years, is that we came to this like platforming type agreement with GE, and kind of everything is kind of coming together all at once.
Yeah, that punctuated jump, David, is pretty different, I would say, for a lot of other healthcare practices across the country that say more serially upgrade their equipment. What sort of equipment are y'all working with now for performing your cardiac imaging? Is it the entire fleet of those 23 or almost 23 new CTs, or is it a specific subset of them?
Well, it's interesting. We originally were not planning on using the entire fleet of 23, and now they're not all installed. So the agreement was made, and we currently have, I think, 5 have already been installed. But our idea was originally that we would get 2 of those would be 16 centimeter detector scanners, and we would do our cardiac CTA on these 16 centimeter detector scanners in our outlying smaller hospitals that had, we had decided to go with an 8 centimeter detector minimum because we knew that this was going to be a long-term situation, and we were going to do this. We're going to install these scanners, and they're going to be our fleet for the next 10, 15 years. So the idea was we would scan on the 16 centimeter detector for our cardiac imaging. But what happened was the first one that got installed in 2023 was an 8 centimeter detector at one of our outlying campuses, the Upper Bucks campus, which is it's a smaller hospital, but it is a place where we had been doing the coronary CTAs because that's where we had our VCT previously. Anyhow, when that got installed, we started doing coronary CTA, and immediately I think we realized that there was no reason to limit our coronary CT angiography to just the 16 centimeter detectors that we were planning to install. It was not difficult to train our techs to do the coronary CTA on that. Our table time decreased, our quality was incredible, and also at that same time, as this is all happening at the same time as demand is increasing for coronary CTA, and we realized, we are going to be able to offer coronary CTA at every place where we have this 8 centimeter detector. So that's going to be our overall plan. And as the scanners have been installed, we have really had no problem starting up our coronary CTA programs at each site. So we still do triage some patients. So patients who we think we're going to have a very difficult time getting their heart rate down, we will triage them to our 16 centimeter detector where we have the better temporal resolution. But we are perfectly capable of doing coronary CTA at all of our sites that have the 8 centimeter detector now, which is really fantastic because, as you know, with the volume that we expect to see in the future, we're going to need to be able to do them close to where the patients are.
David, there is so much interesting stuff to unpackage there in terms of the workflow changes that y'all were able to achieve with this new equipment. I want to start with the last point you made first and then talk about the workflow changes next. You mentioned volume increases. Of course, us imagers across the country are feeling volume increases in cardiac CT and beyond. What sort of target volumes are we talking about here? Meaning, how many exams are we performing per day across your sites? And is this at its maximum capacity, or is there a goal for more?
Yeah, well, that last part, we're absolutely not at our maximum capacity, and I think, if you're going to SCCT this year, you'll hear a lot of stories about how the volume is going to be increasing, and it seems pretty evident to, I think, those of us that are doing a lot of coronary CTA that we're not close to maximum capacity because we have a lot to offer, and it's just not fully understood by everybody. It takes time for, I think, ordering patterns to change so drastically that you're going to a CT first pathway with all of your cardiologists. That's just not going to happen overnight. But what has happened is that we definitely have an increasing volume. One thing that was also holding them back, and I'm sorry, I'm kind of scattering around here, but another thing that was holding back volume was that we also weren't able to meet demand originally. When we just had one VCT, we did not have enough table time to get every patient in within a week or 2 weeks. You really, a patient with chest pain shouldn't be waiting more than 10 days for a coronary CTA if that's what they need. So again, a lot of cardiologists felt, well, we can't get the scan when we need it, and it's hard to order, and our reimbursement's not great, and all of those things are changing for us. So our volume has grown. We're definitely not at our final volume. So what volumes do we expect to achieve? Well, I think that's a moving target because as I said, we would like to meet our full demand. Whatever the cardiologists are requiring. I think we'd like to grow our offerings so that we don't have backlogs. Currently, we're up to about 35 cases a week, whereas before we started this, in 2022, we were doing about 4 cases a week, whereas we just did not have the scanner and table time and capability to do the scans. But what would I expect our volume to be? That's a tough question because it very much is dependent on cardiology demand. I would expect we're going to be at 50 a week before the end of 2025 because we will have we're bringing that fifth scanner online in the next couple of weeks. So that would add to our ability to kind of give more table time and also to offer this study closer to some more outlying patients. So I expect by the end of the year, we'll be at 50 cases a week, up from 4 cases a week in the early 2020s. And then in late 2026, I expect another large jump in volume because we happen to be opening a heart and vascular center at one of our main campuses, and that is going to have a scanner in the heart and vascular center with the intent of it being predominantly a cardiac imaging scanner.
David, we're talking in not a very long period of time, about 3 years, an exponential increase, an order of magnitude increase in the volume of examinations performed. And as you've stated, you're not yet at the maximum capacity either by supply or demand. There's got to be more to it here than hardware. I presume some protocol or workflow changes must have come into play. Could you talk to how either patient preparation, nursing staffing, and technologist staffing, or just examination times were improved with these new scanners?
Absolutely. In fact, those may have been, those were barriers and limitations that would have absolutely precluded us from kind of making these volume jumps. We were using an hour of table time to scan our coronary CTAs with the VCT scanner. Now, part of that was, our network was committed to the cardiac program, even though we kind of weren't showing the volume results. But they think they knew that this was going to be something that we were going to want to do. So we were taking a full hour with the patient on the table to give them beta blocker to get their heart rate down so that we could get a quality study on a VCT. When we started scanning on the 8-centimeter detector with the Apex platform, because of post-processing improvements, because of the larger detector width and the greater temporal resolution, and because of the quality exam and the ease of use for our new techs, we were able to cut our table time to 20 minutes. And honestly, we don't even use the 20 minutes for each scan, so that kind of leaves usually it leaves a kind of a buffer. I think we could probably get down to 15 minutes per scan at most of our sites, as long as once everyone's ready to go. But we leave a little buffer in there just in case, which they use the scanner for that, for ER cases if they have to. So yeah, those things absolutely allowed us to grow our volume, because I don't think we would have been able to absorb that table time loss if we, at each of our scanner sites, because we are using these scanners for other work, not just coronary CTA at each site. So yeah, those are the things that technology allowed us to do, to fit more patients in.
David, to get more into the nitty-gritty details there, you've cut the exam times into a quarter of what they were before. Is that implying that the medication usage has been reduced, or are other throughput related things shifting? For example, patient transport, ease of performance of other non-coronary exams?
Yeah, both of those things. One is that we definitely have, because we've created an economy of scale where we were only doing 4 a week. We would bring in our nurse and our specialized technologist who was comfortable doing the scans, and they would only be the only people who had experience in dealing with the patients, and being comfortable doing the scans. So now that we're doing a lot more of these cases, and with the improved ease of use of the scanner, you don't need a tech who has had well, they've had just a few moments of special training, but for the most part, the scan is similar for them to perform as a CT pulmonary angiogram. So the tech is not a limitation. The amount of beta blocker that we give is usually less, but also because we have worked hard on creating a pre-medication regimen that the nurses discuss with the patients prior to them showing up. They're usually better rate controlled before they get on the table, so that cuts into the table time. And we definitely do not have to get the heart rate down as much as we used to. So we can accept a higher heart rate. The other things that we can accept are a much higher calcium score. I mean, I'm constantly shocked at the kind of quality of the exam that we're able to achieve with higher calcium scores. I used to try not to scan patients with a calcium score over 1,000 or 1,500, and I routinely get, I think, pretty interpretable, certainly interpretable examinations with calcium scores in the 2,000 to 2,500 range, getting extremely useful data for patients with these higher calcium scores in a time frame that was definitely not achievable with the older scan technology.
David, I want to transition into talking now about the relationship that you've built and bolstered with your referents. Obviously, the high quality, high throughput program that you've created thus far, I'm sure, is giving your referents a substantial amount of additional diagnostic information to manage their patients. Where are these referrals coming from? Is this in the mostly outpatient space, mostly inpatient? Are they primarily cardiologists? And if so, what types of cardiologists?
Yeah, we're getting nearly all of our referrals from cardiology, 95%. I think partly that has to do with the reimbursement situation. And I don't know if this is only Pennsylvania, but it's kind of difficult for primary care physicians to navigate the pre-authorization process for coronary CTA in Pennsylvania. So all of our patients have seen a cardiologist. We have great relationships with our cardiologist. We have one cardiologist who reads coronary CTA because our cardiology department kind of wanted to be more integrated, and they had someone who had done an imaging fellowship. So he reads the cardiac portion of some exams, and then we have a radiologist that overreads it. Our partnership with cardiology is I think it's great. Also, this cardiologist, because we have this great relationship with him and with so many of the other cardiologists, he acts a little bit as a I don't know how to describe it. He's like a political go-between for me and them. So when some cardiologists have questions that are more clinical, they might address them to this cardiologist who does have imaging specialty. And it's almost exclusively diagnostic cardiologists who are ordering this, especially those who are a lot of younger cardiologists are more familiar with the literature that is telling them just how useful a CT first pathway for diagnosis of low to intermediate risk chest pain is. And so I think that makes them more likely to order the exam in this way. We have always had a lot of referrals for equivocal and nuclear medicine stress tests. And I kind of built relationships with a lot of those cardiologist by being in text contact with him whenever I have a result that is unexpected or interesting in some way. So we kind of build relationships that way. We're able to send them pictures through our secure messaging chat situation, and kind of by doing that, eventually by getting it's helpful for me because I get a lot more clinical information about the patient and I feel more clinically relevant to the patient's care. And it's just great to build those relationships, and then they trust more that the information they're getting is helping their patients. So yeah, it takes time. It takes time to do that, to build this kind of relationship between cardiology and radiology. But I think it's essential to building a program like this because if you don't demonstrate your clinical relevance, it's not enough to just put a report out there and say, okay, well, I've contributed to the patient's care. I think you really need to explain why you're clinically relevant in through your communications individually with the cardiologist.
Yeah, David, I love that. There's a local and global approach to growing any of these programs. The local approach being these exact relationships that you're fostering with your referents and your other imaging cardiologists. And there's the global approach to just the data and literature that we have supporting the use of coronary CT or cardiac CT in general for improving care in these patients. And that sort of dovetails into the new primacy of the CT first mentality for obtaining diagnostic info about patients with chest pain. That said, the CT first mentality is in the middle of this very complex reimbursement landscape for cardiovascular imaging. Wonder if you could dive into the details of that, perhaps even in your own local environment. You had mentioned that Pennsylvania has some complicated reimbursement processes and how that may have impacted the use of CT as opposed to other modalities in evaluating patients with cardiovascular diseases.
Sure, and that was, you're exactly right, Praveen. I mean, the way you say that is that the complex reimbursement environment has a huge impact on the cardiologist's ordering patterns, and also it becomes very complicated by network, depending on what the network incentives are for ordering these, and also the size of the network and the ages of the cardiologist, because it doesn't sound like that should make a difference, but depending on where a cardiologist trained, they may have been using a CT first pathway already as a fellow, and if if they've been doing that and they're a younger cardiologist, they come out with that idea that they want to use a CT first pathway. So all these things are factors that go into the demand for your services. And also the understanding of where those services fit into the patient's care. As you mentioned, the reimbursement recently has changed. CMS moved coronary CTA into that higher ambulatory payment classification. So the payment rate went up, I think, to 300, from 175 to 350, something like that. And for us, that didn't have a huge, immediate impact because, we still had the ordering patterns in place. But I think from the global perspective, from that zoomed out perspective you were talking about, it represents a recognition from CMS that coronary CTA is on its way to being the frontline test for chest pain. And I think that recognition just adds to the overall cardiology awareness that CT first is the future. So it's a kind of a tailwind for the continued shift of the imaging pathway to go from nuclear medicine towards CT first. Yeah, and for us, it's hard to measure. So there may be some impact there, but it's hard to measure. What are the exact forces that are increasing our volume? It's kind of all these different factors that are coming together at the same time. But all of them pointing in the same direction, which I think is it's useful for our strategy. So if we know that every 6 months our volume is increasing by this certain amount, we really have a kind of momentum in one direction, and we can kind of plan for the future.
Focusing in on that idea of strategy and planning for the future of the expected volume growth, you mentioned that you have a multitude of hospitals and outpatient imaging centers across your whole health system that you are covering. What sort of decisions are being made as to geographically or timeline wise where to place these, we'll call them cardiac capable scanners in your system? Do you have heterogeneity in terms of geography or timeline, or is it still a problem to be solved?
Well, it's lucky for me because these would be really difficult decisions, but they're mostly made by the end of life scanners. So we basically have to install the scanners at the sites where the previous scanners is about to or ready to fail. So that has made a lot of the decisions for us. So we can't do them all strategically where the demand is. But the other thing that we have going for us is that the hospital presidents at the outlying campuses when they get a lot of information from their clinicians that their clinicians have been sort of unhappy with how far their patients have had to travel to get their coronary CTA, they come to us and say, hey, we need to move ourselves up. So we kind of get word of demand starts to reach us, and then they kind of fight it out. And luckily, it happens at a level that doesn't reach me personally, so I don't have to get too involved, which is nice. But I hear secondarily about the desire for our services, and so that is also good for us planning on other things that we need to get ready for, which is how many radiologists we're going to need to read these, or how many radiologists or cardiologists we're going to need to have available to interpret these exams, which is another factor that we think about.
Yeah, David, I think that's a good problem to have. Rather than marketing for oneself to get cardiac imaging and cardiac CT out there, as was probably done a little more than a decade ago, now there's those that are fighting over where would they get it first. So that's awesome problem to have, really.
Absolutely. And I definitely remember me going out to try to ask them to order cases. And now it is nice to be in the situation where the question I have to answer is not where we're going to get the patients from, but where we're going to get the scan time from.
David, I want to touch on one final topic before we come to the close of our conversation. It's what we often describe as the halo effect of cardiac CT in a particular environment. So this includes things beyond the imaging. For example, enriching cath lab referrals or the growth of a structural imaging program. Could you speak to these halo effects of the cardiac CT program that you've helped bolster?
Oh, absolutely. I mean, that has been huge for us reputationally, at least from a radiology perspective. Probably the biggest thing, as much as I'm really proud of the coronary CTA portion of the program, and I think it's the most clinically impactful portion of the program because it's going to keep growing and growing. We had a real problem with our cardiothoracic surgeons who were very unhappy with the quality of our pre-TAVR CTA. We had a VCT that it was doing okay, but we would have far too many cases that had to get rescanned because of cardiac rate being too high and just not getting a really good, very accurate assessment of the annulus. And this was at a time, just as a kind of funny story, the interventional radiologists were interpreting the TAVR imaging at that time. And I remember saying, like, well, the division of cardiothoracic will take it over. We're just give us a few months until this scanner is installed, then we'll take it over. And thinking, I'm going to look like a hero because as soon as I take over, all the interpretations there's never going to be any complaints anymore. And that's exactly what happened. Is that ever since the 16 centimeter detector scanner was installed, every TAVR case is perfect because it's one rotation, and the annulus is very easy to image in one rotation. It's very easy to image in one rotation on an 8 centimeter detector. So that made me look great, and the cardiothoracic surgeons are very happy with that. It's a massive improvement. No one has to get rescanned for TAVR because they come out great. But we also are offering a lot of other stuff. We're offering left atrial appendage, so we can kind of keep patients from having to go through unnecessary transesophageal echoes. Now they're doing planning for transcatheter tricuspid valve replacements. That's part of the halo effect. I mean, I think the cardiothoracic surgeons say nice things about us, and that gets back to the cardiologists, and that gets back to the network presidents, and that kind of stuff is, I think, very valuable. I think the community hears about coronary CT angiography, and they hear about, we've started using HeartFlow, CTFFR, and so that definitely all contributes to, I think, a halo effect that's good for your department, but it's also, I think, good for your network.
David, let's conclude now by talking about your future steps for the department and what you're most excited for in cardiothoracic imaging, either where you are or in general.
Sure. Well, our next steps, I think, are mainly tied to growth. So, as I mentioned before, we were opening a heart and vascular center that's going to have a CT scanner in it. I see a transition to CT first pathway being something that may take, 4 to 5 years before it's the standard imaging for chest pain will be CT first, is what I'm hoping, and I think we're seeing things move in that direction. And I think we'll be able to help quite a few patients by doing it that way. I think we'll have an easy time at that point once we get this greater volume of demonstrating that we have increased the yield in the cath lab, so that only patients, not exclusively, but the far greater percentage of patients who go to the cath lab will only go because they need revascularization. And I think if we can show that, I can feel like the original promise of coronary CTA that we kind of first started out hoping for in 2004 will be fulfilled. I mean, just think about how many patients that have gone through unnecessary, digital subtraction coronary catheter angiography that we could keep from having to do that. I just think that'll be great. So I guess that's what I'm looking forward to. I think it's very achievable, and I think we're kind of well on our way to that. So that's pretty much it.
Love it. Thanks, David. Thank you so much for sharing insights about your program and how you've grown it to its robust practice that it's at today, and also talking about the future direction that you're taking it. Thanks for your time on the podcast, and looking forward to hearing more from not only you, but other members in your service about the growth of cardiac CT at St. Luke's. Thank you so much.
All right. Thanks, Praveen. It was great talking with you.
Of course. To our listeners, of course, thank you for tuning into the podcast. We really, really appreciate all the time and effort you dedicate to giving us feedback on these types of topics. If you like what you hear from us, please go ahead, rate, review, and subscribe to us. That helps others out there find content like this. Once again, this is the Donut of Destiny. Cheers.